Okay, good afternoon, everyone. My name is Dr. David Kanashko. I'm the Director of Education and Training at Meditech International in Toronto. We, of course, manufacture and operate a clinic with BioFlex laser therapy devices. Today's topic for the webinar, by the way, I haven't done a webinar for a couple months or so, and I do have some new ones listed, including obviously today's. So just check with our website under events and under webinars, and you'll see the up and coming webinars as well. The topic today I decided to do because during our trainings and in general questions I get asked, oftentimes reflect around how deep does light actually go, how deep can I treat tissues and joints in the body, how much dosaging, how much light do I need to be effective. And there's not an easy answer for all this. The goal of today's webinar is to actually try to get down to the bottom of this. There's a lot of misinformation, putting it politely, on the internet and on different sites, other manufacturers, that quite frankly is completely inaccurate. So hopefully by the end of today we have a better understanding of light and its properties, how it travels through tissues, and what kind of dosaging do we require in order to have some kind of positive effect on our patients. So thank you very much for joining in. Remember, for future webinars, even if you can't join us, please register and you'll be sent an email with a link to watch the webinar again whenever you like. So if the time zone doesn't work, or you need to or you have something going on, then you can still listen to the webinar. However, if you don't register or after this webinar, the webinar is edited and saved, but it's saved on our platform that's password protected, and of course you would need to have our equipment in order to get a password and username. So just so that everyone understands that. Okay, let's move forward. So what I'd like to do today is again go over the definition of photobiomodulation therapy, or of course we know that as laser therapy or low-level laser therapy. I'm going to briefly discuss the mechanisms of action, which most of you are probably familiar with, and review what photoacceptors are and why they're so critical in understanding how this light travels through the body. And then I'm going to talk about the effect of light wavelengths used and why they're used. And then I'll get into how deep this light can penetrate, through what tissues, even through the skull. And I'm going to refer to research, as I tend to do. So this is coming from research, not just some random person on the internet. So you can feel free to check out all the resources that I've been, and the references that I give as well. Then I'm going to talk a bit about dosaging calculations and the importance of dosaging, and what dosages seem to be helpful. And then after that, I'm going to have a very big news announcement. So hang in to the very end, and I have a very interesting flash of news that I think you might be interested in. Okay, so remember also that you can ask questions at any given time. Just write them down. There will be time for questions at the very end. I'm getting some information right now. Someone's saying... hear anything? Okay, there is no video. Okay, I don't know. Hopefully everyone can hear me and can actually see what's going on. Please just type in that you can hear me, which I believe everyone can. But also, if you can see the screen as well, which I don't know. No, there's no video of me, Flavio. Okay, so I'm getting a question here. Flavio, no, you won't see me. I am camera shy, so it's just the presentation. Okay, so photobiomodulation therapy, as we all know, is a form of light therapy. It uses non-ionizing forms of light. So that light can come from a laser, it can come from SLDs, LEDs, broadband light, as long as it's in the appropriate wavelength, which is in the visible and infrared spectrum. It's a non-thermal process. Everyone out there needs to understand that the source of the light should not be heating. So the source of each diode should be under 500 milliwatts. That's the threshold of thermal light. And this whole process involves endogenous chromophores, which are photoacceptors in the human body. And if they're stimulated, then this can elicit a photophysical and or photochemical event at various biological scales. Which sounds very complicated, and it is. So this process results in beneficial therapeutic outcomes, including but not limited to helping reduce pain, helping decrease inflammation, modulating the immune system, helping with healing and tissue regeneration. So really, that's the definition that we know of, and it looks to me like everyone can hear and see me, so that's awesome. So what are photoacceptors? Another name for those are chromophores. And of course, I'm going to use this example a couple of times today. We know in the plant world, chlorophyll converts light energy into chemical energy through chlorophyll. So that's a very commonly known photoacceptor. Carotenoids also accept light. And of course, that's what we see with the changing colors in our leaves this time of year. In humans, we have all sorts of different type of photoacceptors. In the retina, there's rhodopsin. In blood, there's hemoglobin. In your skin, there's melanin. In muscle tissue, there's myoglobin. And nearly all cells have enzymes called cytochrome, and these also absorb specific wavelengths of light. And that's really our target, is cytochrome. So again, this is a review. I'm thinking for almost everyone out there, but I do like to do this. We have a mitochondria here. If we open up the mitochondria and look closely at the inner membrane, we know that there's embedded enzymes of the electron transport chain, or ETC, and the terminal enzymes are this enzyme here, cytochrome C oxidase, and one that's not shown here is ATP synthase. So what happens is when you have inflamed or damaged cells and tissues, you start to increase intracellular nitric oxide, shown by the NO in this orange blob here. Nitric oxide in high concentrations inhibits ATP production in cells, in the mitochondria. It does that because it preferentially binds to copper and iron subunits, thereby blocking oxygen from binding. And it slows down the cell's ability to undergo aerobic respiration, or basically thrive. Now, what they found was that when you expose these enzymes, cytochrome C oxidase especially, to very specific wavelengths that are in the active absorption spectrum, and I'm going to talk about that shortly, then it actually breaks the hydrogen bond between nitric oxide and copper. Nitric oxide is a freely diffusible molecule that can go through the membrane. And as you bombard these cells, it allows oxygen to bind back onto copper, initiate and get aerobic respiration going again, thereby increasing ATP production and respiration rate. So on a biological scale, that's what's happening inside the cell. Even a little bit more in depth, which I won't spend a lot of time on, is here's the cell, here's the light coming in, here's the light being absorbed by cytochrome C oxidase along the respiratory chain. And what happens there is you get an increase in ATP, you get the release of nitric oxide that can actually diffuse outside the cell, and then you get a spike of something called reactive oxygen species, which is an oxygen molecule with a triplet electron. This will stimulate in low quantities enzymes that are cytoprotective in nature, proteins like nuclear factor kappa beta, that allows the cell and protects the cell against inflammation and stress. And there's some other mechanisms like calcium ion channel, sodium potassium channels, but I won't get into that right now. Okay, so what is action spectrum? An action spectrum, basically, it's a graph of the rate of a physiological activity plotted against wavelength of light. So it shows which wavelength of light is most effective used in a specific chemical reaction. So remember, we're talking about a photochemical reaction. Okay, so for example, again, in plants, chlorophyll is much more efficient at using or absorbing red and blue regions of the spectrum compared to, say, green, which is why leaves appear green. And this allows photosynthesis to occur. So the action spectrum of the graph will show spikes along these wavelengths, red and blue, that actually initiate photosynthesis. So as an example, here on the bottom is wavelength, on the left is absorbance, and you can see that chlorophyll, there's two types, B and A, absorb preferentially wavelengths in the blue and the red zone. So these are the wavelengths that stimulate this enzyme to be more active. Now let's take a look at cytochrome C oxidase, because that's what we're concerned about. Remember, this is an enzyme that will trigger and help make ATP, which is the chemical source of energy. So the absorption spectrum for cytochrome C oxidase has a high peak in the green and yellow and orange, and then starts to lower down into the red zone, and then has another peak in the 780 to 900 zone, and then it starts to peter off again as you get past 900 to 1000. So that all this means is that certain wavelengths are absorbed by cytochrome C oxidase and actually make it more active, make more ability for it to have this photochemical reaction. In the human body, blood also highly absorbs light in the green and orange, yellow wavelengths, lesser so in the red, which is why blood appears red. And you can see it really tails off at around 630 or so, 620 nanometers, and then really tanks off past that. On the far right, as the wavelengths get higher and higher, water starts to absorb, especially close to 1000 and above. So there's a window, as you can see, of peaks that might be preferential to avoid excessive blood absorption and excessive water formation. And those peak wavelengths, as you can imagine and you can see here, are going to be roughly 630 to 680 nanometers, and then again a smaller peak at around 780 to 900 or thereabouts. So this graph is from Tina Carew. Tina Carew is the most eminent professor and researcher in this topic. She is from Russia, and her work has been done since, I believe, the 70s and 80s and 90s, even the 2000s. And this is showing you different peaks of light that's activating cytochrome C oxidase. So you can see there's a peak at 620, a peak at 680, a peak at 760 and 820. So anywhere along these peaks or close to those peaks, you will stimulate cytochrome C oxidase, and you will increase the ATP production. So this particular graph taken from a paper shows that exactly. So what you're seeing here at the bottom is the cytochrome oxidase absorption spectrum, and at the top you see that when you change the wavelength, the ATP concentrations will start to go down and then start to go up and then start to go down depending on the wavelength. So in other words, and of course that will correlate with cytochrome oxidase activity as well. So in other words, when you expose cells to wavelengths, around you can see here around 660, 630, it's very efficient at producing ATP, but then it starts to bottom out past 700, and then it has another peak at around 830, 840, around there. So if we choose this peak and this peak, those are the preferential wavelengths used because we know that they're absorbed by the enzyme and activate cytochrome C oxidase. I'm hoping I'm not going too fast, but I have so much information to get through. Someone says they can't hear me. I don't have any sound. I don't know. I am seeing that almost everyone can hear me. So just try in again if you can still hear me. I can't solve a problem unless it's happening for everyone. So I think everyone can hear me. Okay. So let's continue on. So when the action spectrum of cytochrome C oxidase activity and ATP content of neurons, this is a research paper, responding varying wavelengths were plotted against a known absorption spectrum of the enzyme. They also concluded that 670, 830 nanometers seemed to be the most absorbed and most activated wavelengths. So all I'm basically saying, according to Tina Carew and many researchers, that the best wavelengths to use for photobomb modulation seem to be around 630, 660, 780, and in the low 800s nanometers. So those are the wavelengths that we know are going to have the best result for photobomb modulation. And there's a reference there. Okay, let's talk about penetration, depth of penetration of light. This article, Effective Pulsing and Low-Level Light Therapy by Michael Hamlin and Hasmi and the rest of them indicate that the most important parameter that governs the depth of penetration, in this case of laser light, has to do with the wavelength. And again, that is because if wavelengths that are used that are absorbed by melanin or absorbed by blood are not going to penetrate very well into the human body. There's other factors to take into consideration, like the tissue density, bone, tendon, and muscle all differ, the skin color, blood perfusion, hair, adipose tissue. These are all factors that affect the depth of penetration. So a chart from that paper kind of indicates and shows, different absorption spectrum. Basically, I'm going to talk about this as we go along. So another paper by Hudson et al., they used two different wavelengths. They used near-infrared at 808 nanometers, and they used 1 milliwatt per centimeter squared. Sorry, I'm going to back up a bit. When they used 808 nanometers of laser light, and they used the same intensity of 980, what they found was when they used a power density of 1 milliwatt per centimeter squared, the light penetrated to 3.4 centimeters. It was bovine tissue. Or, I guess, bovine is a cow. And then when they use 980 nanometers, remember, 980 is highly absorbed by water. And it only penetrated to 2.2 centimeters because of the drastic absorption by water. So when you're looking at a device, and if that device uses wavelengths greater than 900, and they're saying that it penetrates really deeply, I beg to differ, only because this is what the research says, and it certainly makes sense because we know that water absorbs in that spectrum. So the conclusion here was that 808 nanometers penetrates 54% deeper than 980 nanometers in bovine tissue. Another paper by Juanita Anders compared 808 nanometers with 904 nanometers. 904 is a popular wavelength. It's not that it's a bad wavelength. It's used by superpulsed lasers. But again, the issue is penetration. So superpulsed, according to Juanita Anders in her research, she found that 810 nanometers it actually penetrates deeper than superpulsed. And you can see here the result, 24.63% of penetration compared to about 20% for skin and muscle, and 7.24% and 4.01 with respect to skin and muscle. So the first one was skin, and the second one was skin and muscle. As you go into muscle tissue, you would expect much less light because it's being absorbed. Okay, and that's the reference right here. So, what is the real depth of penetration? And this is a challenging question to answer, and it can only be answered as a range. And that range would be red wavelength, because it tends to be absorbed to some degree by melanin and to some degree by blood. It's only traveling millimeters to centimeter or so into the body. Infrared wavelengths will penetrate deeper, perhaps several centimeters. But again, we're not looking at really, really great depths for red. And for infrared, depending on how you treat and the tissue density and other factors, there's a possibility it can go several centimeters or an inch or two for our American listeners, depth into the human body. So remember, even though light can reach a certain depth, it's the dosage of the light at the depth of your target that's most important. So this is the effective therapeutic dose. Even though light can go 5 centimeters in the human body, it does not mean that that light will be effective at 5 centimeters in the human body. I'm hoping everyone can understand that. So essentially, you have to recall what the Arndt-Schultz curve and how it relates to photobiomodulation. So let me give you an example. Here is the Arndt-Schultz curve. And basically, this curve applies to light therapy. There's a dual response, or a dual dosage response. If the light from A to B is really weak, then nothing will happen. As you increase the intensity or strength of the light, you will get a greater reaction, or a reaction and a greater reaction, or photobiomodulation reaction. And when you get to the very top, that will be your optimal reaction. However, if you continue to use greater amounts of light, dosages, then this response will start to decrease. And then if you use even huge amounts or dosaging, you have the potential to be inhibitory, which is showing E1 to E2. So in other words, for dosaging of light therapy to be effective, you need to be between B, C, and D, and avoid A and B, and avoid really E1 to E2. Even though you can be effective between D and E1, it's not going to be as effective as C and D. So the dosaging has to be accurate. This editorial was published by Cecilia Young and Chiok Lam Mak, and it was titled Low-Level Light Therapy, Penetration of Photobiomodulation. And I like this editorial because it really succinctly, I didn't say that word right, applies to photobiostimulation. So it says here the incident light needs to be delivered to the target tissue in proper dosage. Therefore, the penetration of light used is obviously really important. The optical properties of the light depends on the body tissues and the wavelength. So despite knowing correct ranges of wavelength, the skin is still the greatest barrier to LLL treatment. Again, think of the Arndt-Schultz curve. So the skin will block out most of the incident energy by scattering, absorption, reflection, and so forth. Thus, the energy dosage for the deeper parts of the body remains at the far left of the Arndt-Schultz curve, meaning way over here, because most light is being absorbed. So in other words, all I'm trying to say here is that you need to have a lot higher dosage at the skin in order to perhaps get enough dosage deeper down to have a reaction, a photobiomodulation reaction. So what happens if you increase the incident energy? So in other words, let's say I have a 100 milliwatt probe, but I'm going to now use a 1,000 milliwatt probe because more is better. Okay, well, the problem here is that, remember, it's biphasic. So in other words, biostimulation occurs only in low doses. That's why this used to be called low-level laser therapy or low-level light therapy, because high dosages can cause bioinhibition. Okay, so everyone out there may have heard of class 4 laser therapy. Maybe you have class 4 laser therapy. It's effective for thermal effects. It's not effective for photobiomodulation because the dosages are so high it creates a bioinhibition. Absorption coefficient of human tissue is independent to light amplitude. In other words, what I'm saying here is that it doesn't matter how much light you pour into the skin, there is a certain amount of absorption taking place because of melanin, because of blood, because of all these different photoreceptors that get in the way. So although increasing the incident energy can deliver the appropriate energy to the deeper parts, it may result in bioinhibition to superficial layers. This is a problem if the superficial layers are also injured, diseased, or have inflammation going on. So, can light penetrate a skull? I'm hoping that I have enough time to get through this. Wow. Okay. So, here's some research. This particular paper estimated that the mean penetration depth, in other words, there was about 5% remaining intensity of near-infrared light that went to the scalp and the skull, was approximately 23.6 millimeters. They used human cadaver heads with intact soft tissue but no blood flowing, and they measured 830 nanometers of light, and they found that 0.9% penetrated the temporal region, 2.1 in the frontal region, 11.7 in the occipital region. So you can obviously understand that in the temporal region, your skull is thinner. In the frontal region, especially if you're like Cro-Magnon or something, is very thick, as is the occipital region. Red light is hardly penetrated. So here are the results. You can see the red bars are the red light, and this is the percent penetration of light through coronal sections of the cadaver skull. And you can see that near-infrared light, near-infrared light penetrates at a much higher percentage than red light. So they concluded that very low density of light may in fact reach the brain where the near-infrared light is applied to the skull. This direct irradiation may be sufficient to change mitochondrial and neural activity. I mention this because there's so much interest nowadays in treating concussions, traumatic brain injuries, and neurological conditions. Another paper looked at the penetration of 660, 808, and 940 nanometers of light. And again, they found that 808, no surprise, right, was the best at penetrating in roughly 40 to 50 millimeters into the brain. Another paper looked at the transmission of 810 nanometers through the skulls of 4 different species, and they found that mouse was huge amount of transmission, 40%, rat 21, rabbit 11, humans 4.2. And then sorry. And again, this makes sense because the thickness of the skull, as we get to humans from a mouse, increases quite substantially. Okay, let's have a little review about dosaging. Remember that a lot of dosaging refers to joules. So dosaging is always calculated at the surface of the skin, even though our problem might be very deep or deeper than the surface of the skin. So the total dosage in joules, remember 1 joule is 1 watt times 1 second, that gives you 1 joule. We do have to take in consideration how long we're holding the light for. So in this example, we're using 180 milliwatts of light for 10 seconds, and that will give you 0.18 times 10 seconds, 1.8 joules per point. Now, we also calculate fluence or energy density, and that's by the power in, again, watts times seconds, which gives you joules, divided by the surface area that you're treating at the skin. In this example, and what our laser probe is 0.1 centimeters squared, and that will give you 18 joules per centimeter squared at the surface, or that is another term for fluence or energy density. So just to reiterate, here's my source of my light. Let's say that light is infrared, and that light can penetrate to this depth. However, as soon as I turn it on, and if I'm holding it for a certain period of time, even though light is getting this deep, I may only have enough dosage or energy density at this penetration depth to be effective. Everything beneath that, even though there's light there, there's not enough light, think Arndt-Schultz curve, to cause any reaction. So you need to either hold the probe for longer or increase the power. And again, you have to be careful, because if you increase the power too much, it may cause bioinhibition, only to tissues and cells that are inflamed or diseased or injured. So the longer I hold the probe or the light source, the greater accumulation of energy density to the maximum depth of penetration. Okay, I know I'm trying to crash course a whole lot of information in such a short time. So the importance of dosaging, here's a nice little paper, and what they wanted to do is look at the dosaging of treating Achilles tendonitis versus diclofenac sodium, but they used both 1 and 3 joules of 810 nanometers of light. They created tendonitis in the tendons of rats, and what they did was they injected collagenase. They also had control on treated tendons, and then some of them they treated with Voltaren, and some of them they treated with either 1 joule or 3 joules of 810 nanometers 100 milliwatts of light. Here's the normal healthy tendon. Here's the tendon injected with collagenase and Achilles tendonitis. Here's the tendon after 7 to 10 days, I think. I can't remember the time frame. Treated with diclofenac sodium. Very poor results, really no healing going on. Here's a tendon, same time frame as a diclofenac sodium treated tendon. However, it was treated with 1 joule of energy. Clearly, it's actually healed or on its way to healing. Here's the tendon was treated with 3 joules, right? Bioinhibition. No, you can see there's no signs of healing. That's because there was just too much energy. That's what I'm referring to when I talk about bioinhibition. Okay, so importance of treatment time with respect to dosaging. We know that short treatment times are very convenient in the clinical world. We can treat really fast, great, more power, see more patients, yada, yada, yada. But the problem is that the longer the light's applied, the greater the degree of stimulatory dosage into the deeper tissues, right? So systemic benefits also occur to the immune system during this longer treatment times as well. So you have to take that in consideration. So we really feel that, and I think the research feels that treatment times are also important because quick treatment times tend not to be as effective because you're not getting as much dosage into the deeper tissues. Castano and other authors basically went on to say that 8-10 nanometers is highly effective in treating inflammatory arthritis, and they found that when they used longer illumination times, even though the dosage was the same, that they found that it was more effective than the shorter times, regardless of the total fluence or irradiance. So in other words, the fluence or the irradiance or the energy density was the same, but they spread it over a longer period of time, and it was more effective. Okay? So LLOT delivered at low dosages tends to work better at the same wavelength delivered at high levels, which illustrates the basic concept of biphasic dose response, or it's also called hormesis. So in general, fluences, energy densities of red or near infrared, anywhere from 3 to 5 joules per centimeter squared seems to be the sweet spot. Okay? When you get to be really high, like I'm talking really high, then it can be detrimental. So what dosage should you use? Well, really there's not a lot of good stuff out there. If you go to the World Association of Laser Therapy, you can see the website at the top. They do have recommendations. Now, these get a little bit old, but they are based on research. And you can see the reference is joules per centimeter squared. All right? So in other words, you calculate the energy in joules divided by your surface area and how long you're holding it for, and that will give you the joules per centimeter squared. Okay, so you can see here there's some recommendations. I'm not going to dwell on this, but you can see treating tendinopathies, treating arthritis, and unfortunately that's really all they have listed. You have to go to the research and see what's effective, but for the most part, there are ranges, and the ranges tend to be 2, 3, 4 joules per centimeter squared up to 10, 12, or so forth joules per centimeter squared. Okay? So the research is important to understand. That's my role here at Meditech. I go through the research. I try and understand what's going on. And of course, these are the kinds of recommendations that we follow. So, finally, if we have some examples, let's say I use 50 milliwatts. For 10 seconds, that's 0.5 joules per point. If I hold it for 10 seconds but have 100 milliwatts, I'm now at 1 joule. If I have 200 milliwatts for 10 seconds, I'm now at 2 joules per point. Okay, so you need to take this into consideration. Depending whatever device you have, you need to understand how many joules you're putting on the surface of the skin and your target, and will this be effective or not. Okay, so that brings us to the end of the webinar. I ran a little overtime. My apologies. Here is the big announcement. For the next 3 days, 72 hours, starting 12 a.m. today, we're having a flash sale on our BioFlex personal therapy systems. It's buy one, get one free, which is a really, really good offer, or buy one and get 25% off. It's just for today, for tomorrow, and whatever the next day is. I guess that's Saturday. I don't know. But call this number that you see on your screen. And while you're looking at that, I'm going to take any questions that you may have. Okay, wow. Okay, so I see lots of questions. Let's try and get to them. Other than you can't hear me, you can hear me. Maybe you want to see video of me, but I don't think I'm going to do that. All right, let's see the questions. Where are the questions? Okay, by the way, if you're interested in my actual references, please email me directly and I can get you those references, not a problem. My email is straightforward. It's David, D-A-V-I-D, at bioflexlaser.com. Okay, so what if the patient is immunocompromised, such as critical neutropenia? Does the treatment time need to be continuous, or if 2 short sessions of light treatment to 1 long session? Immunocompromised, I don't really think that, you know what, I mean, that's a great question, Joe. It's hard to say. I mean, you have to see how the patient responds, but I mean, if in fact they have neutropenia, then it kind of makes sense you may want to kind of treat for longer. That would be my gut feeling, but I don't have any data to support that. How important is duty cycle? Well, duty cycle is important because if you're flashing a light, that increases the energy, total energy. So the higher the duty cycle, the higher the energy. But there's only a duty cycle if you're flashing the light. So that is really important. I didn't get into that this particular session because I didn't talk about pulsing. Let's see here. Okay. Roger, I see that you have a question. You know, I don't want to get into your question just because you're talking about some specifics, but please email me or reach out to me and I can have a discussion with you on that, because maybe you just need some assistance as far as how to use the equipment. Is there any research available for someone who has nerve pain caused by stroke? There is research on stroke, not a lot of it, mainly in animal models, but some humans, but certainly lots on nerve pain. Jacqueline, so if you want to email me for that, I'm more than happy to do that. What parameters are used for lymphedema? Well, we do have a lymphedema protocol in our equipment, but I can't get into that right now. Are they investigating Parkinson's? Yes, they are, in fact, and I've been seeing some research on that as well. Does light have trouble penetrating through hair? Absolutely. The darker their hair, the more light reflecting and more absorption, so you have to take that into consideration as well. When treating targets deeper than just below the skin... Oh, is it necessary to use the red array when treating targets deeper than just below the skin? Yes, because red light also helps with analgesic effects as well. And also stimulates the blood. Is laser safe for juveniles? Yes, absolutely safe. No contraindications for children, and in the neck as well. Can you develop the example of cervical spine here? I don't understand that question. Sorry, Julian. Maybe you can email me that question. Is there a phone number which I can call from the UK? 844 code is not accessible here. Okay. So good question, Andrew. Andrew, go to our website, and they will have other numbers as well, including a local number, which is a 416 number, and you can call that. So just go to bioflexlaser.com, and you'll see that number as well. Do you feel LLT after fractional non-ablative laser therapy would be productive? Yes, absolutely. After fractional, I think fractional lasers are ablative, if I'm not mistaken, Patrick. I need to understand that question better. But if you use LLT after other forms of laser therapy for skin lesions, that kind of stuff, it's very beneficial for reducing inflammation and helping with the healing time frame. Are they investing autism, Heather? Yes, in fact they are, and I've seen some research on that. There's a couple papers on that as well. Again, my email address is David, D-A-V-I-D, David at bioflexlaser.com. Evelyn, multiple sclerosis, there's definitely uses on it for MS. Maybe I'll do a webinar on that one day. Does it have any effect on cellulite? Perhaps. I think light is showing to have effects on lipocytes. Research is a little sketchy, but I think it can be helpful, Heather. And pulse light is more effective than penetration. I didn't get a chance to actually get into that, but not necessarily with depth of penetration. So yes, is there any research on hydrocephalus? No. Personal care for nerve pain. Jean, so I would encourage you, Jean, to maybe email me or to call us to discuss that, because it can help with nerve pain, but I need to understand what's going on with you first. Wow, these questions keep going on. Will your red array give the same analgesic effects as a red probe? Red probe is more effective because you have a much higher energy density in a very smaller area, but because the red array is used for a long period of time, it's also effective. Okay. Can laser help with tendon contractures? Okay, so laser therapy can definitely help with tendons, tendinosis and scar tissue, that kind of thing. Tendons don't contract because they're not a contractile tissue. So I'm not sure if the diagnosis of what you're saying is accurate, but I'm thinking you're thinking of tendinosis or thickened tendons, in which case it can. Do a webinar on effective lipocytes. Maybe. I'm going to take a look at the research again. Does it work on muscle cramps? It will, oh boy, I suppose, not acute muscle cramps, more on hypertonicity, that kind of thing. Benedict's hand, I would have to look into that one. Will this webinar be available for later viewing? Yes, you'll be sent an email with a link to watch it again in a week or two. It's very helpful for scar tissue softening. That's a whole different topic though, but it can help. How long would you hold it for analgesic effect below 10 seconds? Oh no, so for analgesic effect you have to hold a R-red laser probe for longer than 10 seconds, definitely longer. And I would also use the near-infrared as well, laser probe. But you have to hold it for a long time, 20, 30, 40, 50 seconds. But remember, that's going to be bioinhibitory for tissues underneath it. So keep that in mind. Okay, thanks everyone for joining today. I do have a webinar on the knee and knee injuries and conditions next month. Again, I appreciate your time. And if you're interested in this deal for the personal systems, give us a call. It's only 3 days. It's a flash sale. Then they return back to the normal prices. So, yeah. Anyway, have a great afternoon, and thanks again for tuning in. Bye now.